little bit of introduction.
Thank you.
So obviously, again, welcome to another question and answer session with the PBC Foundation. And your host again today, as always, is our CEO, Collette Thain. And helping answer your questions today is Professor James Neuberger. So we hope that whether you're watching on Click Meeting or Facebook, you have an interesting and informative session. And I will catch up with you later in proceedings.
Thank you, Alan. Thank you. He's going to go. Good afternoon, James. Good afternoon, everybody. And welcome to our cozy little chat on PBC. This is our armchair theatre. Do you remember that used to be a TV programme years and years ago, James? Armchair theatre. Do you remember that?
No.
That with animal magic and Watch with Mother. Yeah,
I'm too young to remember these things.
Right. Okay. Dream on, baby. Okay. Well, thank you for joining us, James. Hello, everybody. Before we start, it's lovely that James is with us today. We've only got 2 Q&A sessions this October, but you know our specialists have done us really, really proud. They're busy. Hepatologists have been asked to help with COVID, so we are going to take this opportunity to ask what we can. So I'll read out the questions. James has a copy, but just so everybody else can hear them. And we've got a couple of carryover questions from last week, as you will note, because last week we had Dr. Alan Bonder from the States, James.
Right.
And we really did run out of time. And what this person is really saying, as you being a doctor in the States, how do we get all of our doctors? We have to communicate together. Now, it's an interesting one. That's only thing they do is send labs to each other, but they don't seem to communicate now. That is obviously somebody's perception of us in the UK. So perhaps, would you like to comment on that, James?
Right. Thanks. I think the first thing I can say is slightly controversial, but the situation in the UK is different in a couple of major aspects from the US. And that is that the vast majority of clinical practice is done within the NHS. And doctors and nurses, for that matter, don't get paid more for more people they see. And therefore, doctors are not in competition with each other, and units are not in competition with each other in the way they are in the States. Does this matter? Well, to some extent, yes, it does. It has both plus sides and minus sides. The minus side is, for example, the competition between doctors in the States is one of the reasons that's being put forward for the opiate epidemic that we're seeing. Essentially, if you go to your doctor and says, I'd like some opiates, please, because my back pain, and he'll charge whatever. And if you don't prescribe it, he'll go to somebody else who does. It's as simple as that. And that is one of the reasons. So doctors are businesses like GPs in the UK. Most GPs in the UK are businesses, whereas hospital doctors at all grades are employed by the NHS, and their work and their remuneration is not dependent on the amount of work they do. And that makes it much easier, I think, for doctors to work together. Because obviously, if your livelihood, if your mortgage, if your repayment of your university fees is dependent on your clinical work and income therefrom, then you're going to do your best to defend your income, which is human behavior. So that's the first thing, that doctors are not in competition with each other. And although we do have for example, Birmingham is competitive with the other major liver units, and we obviously try and be better than them. There's no financial imperative, and there's no financial penalty likewise. And of course, that also means that patients get access to the NHS regardless of income and regardless of cost. So the incentives or the disincentives to share is a great deal less in the UK. There are disadvantages with that approach, which we can discuss, but that's reality. Although we talk about having a national health service, it's pretty fragmented. In the UK, in England and Scotland, Northern Ireland and Wales, they have their own NHS organisations. They have their own blood services. There's a lot of duplication, and that, of course, leads to expense. That's another area for discussion, but there's a lot. If you're duplicating provision of blood services, for example, which I know a little bit about, it's a lot more expensive to do it in multiple areas. We also don't have a National Health Service it's joined up, so different hospitals have different IT systems. Very often, sometimes they talk to each other, sometimes they don't. That's getting better. And of course, there are concerns about sending information electronically from one hospital to another because of the GDPR regulations, which make it very difficult to send information. It's when the government tried to introduce a national database of patients, there was a great outcry in the press and the media. And I hear very much in clinic when patients have bloods done, say, in Hull or Peterborough, why can't you access those blood results? It's the National Health Service, it's ridiculous. And all I can say, yes, it is ridiculous. You ought to have a national database. You do need to have controls, obviously, over who accesses it. And just as, for example, with the police database, I know from my own family who work in the Met that they have to justify when they look things up, and they are checked on it and prosecuted if they do it inappropriately. So there is a systematic problem to try and have good communication. One solution, which a number of hospitals, including our own, are looking at, is giving the patient access to their medical records. Some general practices do that already, and certainly our hospital allows patients to access their blood results, their letters, some of the investigations. And this means that you can access it, you can print it off. And if you, sorry, there's some feedback. Somebody should be on mute, or anyway.
I'm trying to switch this off, right? There we go. Sorry, I didn't press the button properly. I beg your pardon.
Okay. So that is one way of giving the patient control over their health, which is a good thing. But B, it means that, for example, if you take blood locally, it's happened in clinic last week in Peterborough, the patient then can relay it to me in clinic, and that is helpful. So we can send letters, we can send emails securely, but it is cumbersome. I would dearly love to see a much more joined up NHS with a common record, so that we can see GP records, we can see investigations that were done in other hospitals. There's a waste of time, waste of energy, waste of resource, because sometimes it's quicker to duplicate than to wait. Secretaries have to spend time extracting information, copying it, encrypting it, and sending it, and then we have to de-encrypt it and read at the other end. So it's quite a wasteful system. And to join up the NHS, make it national, and you see, for example, if you live in Wales and you go across the border for your hospital treatment, that's a different NHS organisation. It's daft, but it needs a lot of investment, a lot of thought about security. But we do share, we don't share enough. But I know when people in tertiary centres like our own, we're not as good as we should be in ensuring that everybody gets copies of correspondence. As I say, one solution is an IT solution. The other solution is to get patients to have their own data. That does work well, but not everybody wants it. And so it's a long rambling dissertation.
But good enough, no, good enough. It's actually quite interesting listening to how it all actually isn't joined up. Because I know in Scotland it's quite different.
No, across the country it's, and one of the problems which was interesting is the provision of foundation hospitals, which was voted in England only by the addition of the Scottish MPs who it didn't affect. They didn't have it in Scotland. That makes them independent. And I see somebody, Sarah Clark's just written, but certainly hospitals, our own hospital does allow patient access to patient records. And I welcome that. There's one interesting sideline, if we just to rabbit on a little bit. Certainly in our hospital, when patients were given access to their histology and their radiology results, particularly the oncologists, were very anxious about it. They said, oh, we need to tell patients if they've got cancer, and we do it so well, we're marvelous at it. And it'd be awful if they read about it online with nobody like us marvelous people to counsel them. Well, they introduced it anyway. And what they actually found was that patients who were interested would access, they would see the results, they have got cancer, so that when they came to clinic, they were no longer bowled over by being told they had cancer, but they would actually engage with the treatment option and how you're going to deal with it. So obviously there are downsides. There are people who are very upset by reading about it. But on the whole, it's a good thing. And it helps the patient. And I think, you know, if it's about you, with very few exceptions, you ought to be able to know what's written about you, what's recorded about you, correct it if it's wrong. I think it's a human right, and encourages you to take ownership of your medical issues. So sorry about that rant.
No, that's fine. You're having some signal problems, so your mouth is moving differently from the sound. So I'm trying to preempt it. Okay, thank you, James. And hello to everybody who's saying hello from Huddersfield, Edinburgh, etc. And Sarah, I don't know where Sarah's from, but she says, my GP offers patient access where I can access my GP records, but not my hospital records. Patient access is great. It is. But I would also go on to say that I get many phone calls from people saying, oh, the doctor won't tell me my blood results, my liver function and my liver enzymes. And so it is the law that you can have access to this information. So don't be fobbed off. I don't know why they wouldn't want you to know. Maybe James alluded to that earlier on when he was saying that, you know, these doctors seem to think that you won't understand or you'll miss whatever, but you can ask and do. Thanks, James. And thank you for saying hello to everybody. Good question. Can Urso increase the itch?
I saw that question and I looked it up. I think looking at the overall, Urso has no impact on itch. There are some patients who associate it, say it does, others say it makes it worse. I think overall there's no good evidence either way. I mean, it's quite possible that it does. We don't really know what causes the itch. There have been various hypotheses put forward, but the reality is we're not entirely clear. We do know, for example, that obeticholic acid can increase the itch. And to attribute cause and effect is always a very difficult issue. I don't know if you go back to one of the bare facts, but there's a very nice website which gives you the most ridiculous, highly significant correlations. For example, the number of films that Nicolas Cage appears in each year correlates extremely closely with, I think, death by vapors and steam in the United States. The consumption of margarine in Kentucky correlates very closely with the divorce rate. Now, I think those are the ones, but now it may be you could argue that people go and see a film by Nicolas Cage and then go and have a hot steam bath and die, but I think it's unlikely, and so on. So so I think one keeps an open mind, but in general, there's no evidence for a clear association. But when you're dealing with humans, you're dealing with individuals, and different people respond. with Ocaliva, with obeticholic acid, which we know is associated with itch, it's useful to remember that the itch often improves over time. You get a phenomenon called tachyphylaxis, and it may be worth persevering with the urso. But if you think it's urso is causing the itch, discuss it with your own doctor. You could try reducing or stopping the dose. Does the itching go away? Restart it, and so on. It may be due to the preparation of urso. That's worth considering. But an association doesn't mean a cause.
No, I do hear it anecdotally from time to time when people start ursos, they can itch a bit, but it seems to go away in most. But again, as James was saying, try a different urso. There's a suspension, there's a liquid one. Do try different things. Now, I'm just going to. I've got questions coming.
While you're just doing that, if I could just reiterate, that's why it's, for example, the foundation was running this survey on itch, because individual doctors hear what's being said in clinic, but what we'd really like is to hear from a wider group of people. So do please help us get information with the questionnaires.
And we've got one running up on line at the moment. So go to our website, go to that. We've two actually, one in our digital services. We want to know what you think and feel and the itch. And even if you don't itch, your itch is treated. Let us know. We want to hear. And we want to hear your comments as well. If you're immunosuppressed, is it better to have the flu vaccine and COVID booster on separate occasions for the best protection, or does it make no difference at all?
I don't know the answer to that. Is a short answer. Okay. It's interesting that if you have the COVID vaccine, you shouldn't get the COVID vaccine if you've had another vaccine within, I think, a fortnight of the COVID vaccine, unless you have, say, the COVID and the flu together. Now, I don't know the evidence on which that's based. I don't know how robust it is. I suspect it's good, as it's from the regulatory authorities, but certainly immunosuppressed people are being offered their third jab, their booster jab plus flu, and other things being equal. I'd suggest you have both at the same time, but I don't know the evidence behind that.
Okay, thank you. And this lady comes back and says, I live in Somerset. You can ask your GP for the access. You need to request a letter from your GP, which has a login number. Not sure if every GP is signed up, but worth asking. I'm not sure signed up to what. The law is the law. You can have your access, but each GP surgery, I would imagine, would have their own methodology, and it's about security as well. They have to ensure that absolutely nobody's getting access but the patient themselves, because as James alluded to, the GDPR, there's severe fines if you get it wrong, and it's not fair on the patient. It's good to have a tight, secure system in place. If I'm taking the full dosage of Urso for my weight, well, you'll know because the chart's in the box, it's online, and we're about to send you a new chart as well, and it's an imperial and metric measurements. We're going back to imperial. Am I pleased about that? I never moved. But anyway, my levels are coming down, but still not quite at normal range. Is there anything you can do to help it before other treatments are considered? You're diagnosed only just in January 21. Fibro scan shows no fibrosis, no cirrhosis, though I don't know the score, but you can always ask. So the question is, if I'm taking the full dose of reversion, the levels are coming down, but still not quite in normal, so anything else I can do to help it?
The short answer to that is no. Normally, you'd wait a year before seeing what the response is.
It's early days.
We're now moving away from the criteria of a responder to normalizing the alkaline phosphatase. The evidence for that is less strong, but certainly increasing the dose of Urso above 50 milligrams per kilogram per day, you're just wasting resource, really. So there's no benefit as far as I'm aware. In a different condition called sclerosing cholangitis, where Urso is probably less effective, in one trial they did where they gave much greater doses of Urso, those people on the higher dose of Urso actually did worse. Now, different disease, and it's a small study, but I think there's little benefit in going above the therapeutic dose. And if your alkaline phosphatase is still up, then discuss with your doctor.
Yeah,
about
but it is early days, isn't it? Yeah. Okay, in the last 2 months, I've had a dry mouth and eyes, itchy ears, popping feeling and pain, quite severe pain. I saw an ENT yesterday and he said there's a lot of dry skin, which he plans to clean under local anaesthetic. He said it was maybe Sjogren's and to see the rheumatologist. The ENT also said pain is not part of Sjogren's. Just wondered, does the itch and pain in ears sound like PBC symptoms, please? I'm under a rheumatologist with arthralgia, myalgia, and neuralgia in my arms and hands and lower legs and feet all since May 21. Rheumatologist feels it may be another autoimmune disease. She's put me on Plaquenil in September. Now the ear is debilitating pain. That's terrible, isn't it? So basically, just wonder, does the itch and pain in the ear sound like PBC symptoms? They're not sure if they've got Sjogren's, but even if Sjogren's was not diagnosed, they may have the symptoms of Sjogren's, which we quite often see. But I'll let you answer that, James.
Right. I think, again, I'd turn the question somewhat on its head. I mean, the question is, do you have PBC? And that will depend primarily on what your liver tests like, what is your immunology like, do you have anti-mitochondrial antibody and possibly a raised IgM or the other PBC-specific autoantibodies. So the diagnosis of PBC is not made on the symptomatology, but on the biochemistry, immunology, and rarely histology, the biopsy findings. It's important to realize that if you look at people with PBC, 70%, 80% have itching. If you look at people with itching, only a very small proportion will have PBC. So the question is, why is the ear dry? Certainly ear disease is not part of PBC. I know there are the occasional reports of rare sort of dermatitis associated with the middle ear with PBC. I wonder if the irritation and itching in the ear is due to a dermatitis rather than due to the PBC. So it's unusual for the itch in PBC to be localized to the ear. It's normally over the torso, the arms, and the back. So I as I say, do you have PBC? I think the blood test will tell you that. What is the cause of the ear pain? Again, I wouldn't put it down to PBC. I'd look for other causes, other treatment. There was another question about autoimmune ear disease. I just had a quick look. I was not aware of it, I have to say. There are some reports about autoimmune ear diseases, but what I know about that can be written on a small postage stamp and still leave room for the Lord's Prayer. So you need to go to the NT person. How well established the middle autoimmune ear disease is, I'm not sure, but it's certainly not on my list of. So if, for example, I see somebody in clinic who's got autoimmune thyroid disease, autoimmune celiac, then I'm happy to treat that. If it's ear disease, I would certainly look at many other causes. I would have a proper ENT opinion and make sure the diagnosis of autoimmune ear disease is soundly based and validated.
Yeah, and I see. I think it's mature, your pronunciation, your name. You've been referred, so that's quite good. But it'll be interesting to see how you fare after they have your ENT chap has carried out this procedure under local anaesthetic, you may just find a huge amount of relief, and I sincerely hope you do, but please do keep in touch. Anyway, really interesting questions. And thank you for that. Can PBC cause, now this is interesting, can PBC cause persistent indigestion type symptoms? I'm a non-responder in OCA and URSO, and latest USS show signs of cirrhosis. I've been suffering with sensation of nausea, belching, heartburn, etc., which is most of the time. Before James answers that, I would say to this person and to anybody out there, any new symptom, any different symptom, anything that's persistent, get it checked out. And drop an email to your consultant or something, but get it checked out. We don't know how long this has been going on. I don't know about the background, but James, I'd appreciate your comments to this person, please.
Yeah, I mean, quite a few people in my experience do comment about nausea and bloating. Whether it's any more than in the non-PBC population, I don't know. Reflux is not uncommon. Urso, of course, and some of the other medications can also cause bloating and nausea. So think of your medication and whether that could be the cause, and how you can, different preparations, taking your medications at different time. So talk about that to your doctor or nurse.
Mm-hmm.
Some conditions, again, are associated with more reflux. For example, if you get sort of scleroderma, that can affect the gullet as well, the so-called Crest syndrome.
Yeah,
that can give you reflux. Gallstones, again, which are more common in PBC, again, can cause indigestion symptoms. So there are a number of causes, but the key thing to reiterate what Collette says is if it's new onset or changing in any way, don't attribute it to the PBC. Make sure there's nothing else that's causing it, because just because you've got PBC doesn't mean you can't get other conditions. So have it checked out, and
absolutely,
don't just say it's the PBC and assume it's nothing to worry about.
Yeah, always get it checked. I was in touch when diagnosed in July, now in URSO, exercising, pacing, socialising, keeping positive, helping others, sleeping better, working part-time, so feeling a very lucky person. I'm early stage, my consultant said. Great. However, I have a huge problem with my ears and sensory problems. Interesting, I was diagnosed with Meniere's disease 10 years ago, and it was much improved until this January. Now my ears are blocked, buzzing, dizziness, pulsating. I also have brain nausea and Sjogren's, but managing these conditions. Can you ask the expert, that's you, James, have they heard of inner ear autoimmune disease and PBC? Well, of course, we've covered quite a bit of this. I think that maybe I have this. I've had this for 10 years, not Meniere's, as my ALT and AST have been raised for 10 years slightly. You kind of covered that, but do you want to add anything on for this person?
As I say, I know very little about autoimmune ear disease. I'll certainly, after today, go and look it up, see if I can find any more. But it's not something I've come across in practice. But that may be because I've just missed it. Not because it's not there, but I've not asked for it. And people haven't mentioned it. But the existence of middle ear autoimmune disease, I know, I was going to say next to nothing about, that's probably wrong. It's nothing. But I'll find out. But I could, a quick internet search didn't throw up a lot.
Yeah, no, I agree. I went looking it up once on behalf of somebody, not that I would interpret anything I read, but I was curious about it, and I was quite surprised how little there was and how vague it was. So really, I don't want this person to be quite despondent and feel that, you know, we do care about what you're going through. But I would strongly suggest going back to your ENT person and having another chat with them. And see if there's any further tests that could be had, and get them to explain about autoimmune disease, liver disease, autoimmune ear disease. If you don't mind doing that, I think it's always worth to press them for information. So I'm going to give
And
you.
I think, so if I can just say, I think with middle ear disease particularly, it's very difficult to get, I suspect there are no easy blood tests, and to get tissue, which is the other way, of course, of the middle ear, which is mainly 3 bones, is quite difficult. But do please email us in confidence, if you will, when you've seen the ENT doctors, and tell us what transpired, because that's how we learn, that's how we improve.
Yeah, absolutely, 100%. So I'm not quite sure we've got all of this question. I have asked Alan to go back to this person, but I'll read it out anyway. My ALP was 3 times ULN, which I understand means upper limit of normal. I'm not very good at short words. I worked in the legal profession. We had to write everything out. Abbreviation wasn't allowed. What?
But then they say it in Latin and charge twice the price.
Oh, so, actually, 3 times the price. Twice indeed, 3 times. Can you please tell me if this makes me an immediate to high risk of disease progression, and would I then be assessed for a second line therapy at 6 months rather than 12 if my response to Urso is inadequate?
I think different people have a different view. Normally, particularly if you're at an early stage, I'd wait a full year. If it's clearly not going to come down, then you might think earlier on about suggesting second line therapy. It depends how aggressive the PBC is, but in most cases, once you start people on new therapy, it's going to be long term, and I think you've got to be quite careful before giving more treatment. One of the things I've always disliked about Urso is it often changes people from being people into patients, and that's always a bad thing. And if you're giving too lots of medicines, again, you're sort of reinforcing the illness issue, which is not, for the majority of people, not a good thing. Obviously, it is an illness, it is a serious and potentially serious condition. I'm not underestimating it, but you don't want to be reminded of it by having to take your tablets, possibly getting side effects. So I think with these long-term treatments, then you've got to be pretty sure that it's necessary. And I don't, in normal situations, rush to add extra therapy, but always the individual cases need individual approaches.
It's true to say every single one of us is individual. We don't follow past like those. We are individual, as it is with other diseases. Okay, now I'm looking at a different screen, and my glasses aren't good, but I met the opticians last week. I sat on them. Okay, just what a dippy woman I am.
So so was it clear you sat on the optician or the spectacles? I wasn't sure.
I'm not telling you now. I've just received my lab results. Alkaline phosphate is 205 and GGT is 116. I have an appointment today with my hepatologist. Should I ask about adding another medication to my Urso, or my numbers good enough? I've been on Urso for 1.5 years.
I'd talk to your hepatologist about this. As I say, there is a move now, which is slightly outside the current guidelines, to try and normalize the alkaline phosphatase. I think, again, a lot depends on the condition, the rate of progression, other indications. So, for example, somebody of 80, I wouldn't necessarily treat in the same way as somebody who's 40. I saw a patient recently who was 85, who was diagnosed with PBC, the FibroScan, very early disease. And I even wondered whether Urso was appropriate, because, do you want to ask people to take yet more tablets, however safe they are, and they are very safe, and what are you trying to achieve? She was happy to take them, but if she'd have any reluctance or was in no way muddled or found difficulty in swallowing them, I'd have said no. So you have to adjust your treatment to the individual and think. So a younger person with more aggressive disease, a bit more scarring, I'd have a much higher feeling for medication and additional medication.
It's a good question all the same. And it's lovely that you had that chat with her and she was party to that decision, which is lovely. Okay, a good question here. You always get one that makes you smile. I have finally found a good hepatologist, this person says. But if I'm from England to Scotland, can I get them to refer me to a hepatologist in Scotland who knows about PBC? I'm not going to answer that. Yes.
If you could find one, yes.
So we have the Edinburgh Royal Infirmary. We have, I can't remember, I think it was Southern General Glasgow, people who were trained at the Royal Infirmary. We have Joe, is it Leatherhead in Forth Valley Hospital? We've got people up north. I don't know where in Scotland you're going. But yes, there are people who basically shouldn't be treating PBC, don't much about it. Maybe come to me privately. You can get me through the office and you can tell me where about in Edinburgh, in Scotland you're going to be. And we can have a chat about that. But yes, there are definitely centres here. We're not, and we have electricity and all sorts of things in Scotland. Well, that's the room anyway. But yes, there's people that can look after you. I mean, I live in Edinburgh and I've had PBC for 27 years and I've been well looked after. Maybe a wee bit scared of me. That's the rumour. I currently have COVID. Oh, I'm so sorry. Positive PCR with the mildest of symptoms of Delta variant. Well, I'm very sorry to read that. Have run out of Verso and having difficulty getting it as isolating in holiday house in the Western Isles. Will being without it for 3 days be okay?
It's not ideal. I would say, I'm sorry, you've got COVID and so on. It's not ideal to stop the Urso. Certainly, what we do in Birmingham is that I'm able, in fact, we're well set up with IT, so I can prescribe from home. I can prescribe and ask the pharmacy to dispense, and they will send out by courier, if necessary, medication. The other thing that you could do is you could ring your GP and ask the GP to prescribe for the pharmacist where you are on the Western Isles. But I would be uncertain whether the pharmacist would stock Urso or have to bring it in. Would it do any harm? Probably very little, but it's much better to continue taking it. And one thing I'd suggest you do is to pop into the pharmacy there. If they still have pharmacists there, do they?
Yes, but she's got COVID. They're not allowed she's not allowed to leave the house.
No, or ring the pharmacist.
Yes,
you have telephones. They're invented by a Scotsman, of course.
Of course, that's what's been done.
But if you rang the pharmacist, explain the problem, and see whether the GP could arrange for a prescription to be sent and somebody to come and pick it up or pop it through the letterbox. That's preferable. But to be frank, if you stopped it for 3 or 4 days, I don't think you'd come to much harm, but it's not ideal.
But as well as phone your own GP and local pharmacist, phone the local GP as well. Somebody will help you. I'm absolutely sure. So
it's
I'd like
not
to
as though
know as well. Sorry.
Urso is not the sort of drug that you're going to sell on the black market and make a fortune out of.
No. To be quite honest, had I known about it, I would have couriered some up for you. I've got loads of the stuff, but I don't think I'm allowed to do that. But let us know how you get on. I'd be interested to know, because that's an issue that other people, I'm sure, will have suffered or will suffer in the future. It's COVID. You don't go out. You mustn't go out. So another question.
Phone your local pharmacist and see if they stock it, because if you're out in the Western Isle, it may take a day or two to get the supplies in which case it won't be you'll be no better off.
I had my booster last week and advised last week and advised to be sure I also have my flu vaccine when available. Based on your comments about having the flu and booster together, I'm wondering if it will be more detrimental to have with a distance of time. I'm suffering quite a bit after the booster, which was different to when I had the AstraZeneca.
I mean, one hears stories of people who have a bad reaction to one of the jabs. There was some evidence, I think, with AstraZeneca that it was worse after the second than after the first, or I think Pfizer was worse after the second. AstraZeneca's better after the second, and so I think people's responses to the jab are not consistent. And some of the effects can be sort of moderately severe, but they're usually 1 or 2 days. Often you get a fever, sore throat. So there are real side effects, far less bad than COVID, far less bad than, and you don't get long COVID with it. But, taking some paracetamol is probably a reasonable thing to do. With regards to the flu jab, if you didn't have it with the COVID, then I suspect probably to wait. And there is potential arguments for saying to have your flu jab late October, early November may be better. But I think the reality is your GP or the vaccination center, the guidelines are quite clear and they'll be able to advise you appropriately.
Yeah, okay. Can have a trauma to the body cause a fluctuation in labs? I recently had all my teeth pulled and I'm getting implants. I just want to know if my labs change, if that could be a cause. That's quite a trauma. That's a massive thing to do.
Yes. To go on the pool is one thing, but to go on the pool for your teeth is.
I appreciate it because I did not all my teeth, but I did have implants.
Yeah, I mean it's. I wouldn't be surprised if liver tests become abnormal in a number of systemic conditions, so affecting the body. For example, you often see in pneumonia, people can actually get frankly jaundiced. In pregnancy, the liver test can come abnormal. So if there's a mild fluctuation that coincides with that trauma of having your teeth pulled, I wouldn't be surprised. I'd keep an open mind as to whether that was the cause. It could be a reaction to the medication, the anesthetic that was used. If you had antibiotics, if you had painkillers, I'd need quite a lot. So I wouldn't be surprised if that were the case, because in any form of upset to the body, liver tests can become slightly deranged. But watch it and make sure they go back to normal. If they persist abnormal, then you ought to look at other causes. If you become unwell with jaundice or any other worrying feature, again, seek help straight away.
Absolutely. And make sure you tell the dentist and his assistants that you have PBC, and if they want to look at any blood tests or your recent blood liver enzymes function tests, then try and have them available. But do make sure you declare it to your dentist. That's important. Now, apropos the previous question, James, which I wanted to be a bit more information about the ALP being 3 times upper limit of normal. So the person has come back. My ALP level is 497, which is 3 times the upper normal of normal. Can you tell me if this makes me intermediate to high risk of disease progression, and would I then be assessed for second-line therapy at 6 months rather than 12 months if my response to URSO is inadequate?
Yeah, is the answer.
Yes, right. Okay, so get back in touch with your hepatologist and have a chat with them and say to them what you heard here today. The sentence starts, help me understand. We take a bile salt, but we have bile acids too in our system, confused by salts and acids.
Yes, I also, if I remember my A-level chemistry, a salt, acid and salt, but it's the same compound. So Urso is a bile acid. A salt, I think, is a version of the acid, to make it like sulfuric acid and sulfate. But that's not a very good argument. I'm sorry. I think a bile salt. I mean, Urso is a bile acid, not a bile salt. Let me see if I can find it. Yeah. Okay.
Yeah. Shall I carry on, or do you want to concentrate? Yeah. Right. Well, we've run out of questions, which is great. There might be more come in. So you're saying will a long-term gum infection have a bad effect on PBC? You got a long wait for treatment. A long-term gum infection have a bad effect on PBC, James?
Okay. So the difference is you have an acid and a base, and when they come together, the acid is neutralized and a salt is formed.
There you go.
So there you go.
Chicken and egg. So Celia's asking about long-term gum infection. If you do, Celia, please use salt water to clean your mouth on a regular basis 4 times a day, warm salt water. Will it have a bad effect on our PBC, she's asking?
There's several things. If you have gum disease, that may be due to a number of factors. It may be due to the fact you've got liver disease. It may be due to the fact you've got Sjogren's or Sicca syndrome. It may be occasionally some medications can cause gum problems. It may be you're just not cleaning your teeth, and it may be because you're smoking.
Not a gum disease, she's saying it's an abscess.
Oh, an abscess. In general, although people with liver disease are more prone to infections, therefore, if you have liver disease of any cause, that may predispose to abscesses, but it needs treatment like any other abscess, antibiotics, and a dental opinion to know why. But dental hygiene is really important, particularly if you've got Sicca syndrome. And there is an association between poor dental hygiene and heart disease. The link is not clear, whether it's due to things like smoking causing both, or whether there's low-grade infection leads to heart disease. There are all sorts of interesting theories about it. But the dental abscess, I think you need to go. And
but will it have a bad effect on her PBC, is what she's asking?
It might, as we said about having your teeth pulled, might have an impact. It puts an extra strain. Usually the abscess and a dental abscess is usually a very small one, but because it's in bone, it's very painful because it can't expand. So it's usually doesn't, but it needs treatment and proper pain relief. And proper.
Yeah, that's what she's saying. She's got a long wait for treatment. And Celia's in Edinburgh. You know that there is a dental clinic at the Western General Hospital, Celia. So see if somebody can get you to the hospital. They have an emergency clinic. So try your best on that one. And we've got a quick question then. I want to jump over to COVID, James, in our last closing minutes, because I think it's important we cover various things. Alkali phosphorus down from 801 to 225 in 3 months. Bilirubin 16 from 29, FibroScan 19. So significant scanning. Could my next FibroScan show improvement, or is repair unlikely?
you may find some improvement in the FibroScan. It sounds so there's been a very good response to treatment, and therefore there may be some improvement in FibroScan. And certainly, I wouldn't be downhearted if there's no improvement, because what you will be getting is failure to progress. But I wouldn't be surprised if when the FibroScan is repeated, there is improvement. But just to remind you that these measurements are not as precise as one. It's not like, I don't know, measuring the length of a knife, which you can do 10 times and you'll get the same answer. You do get slightly different values on different days, different operators, different machines. So you're looking at the trend. But obviously, if it went from 19 to 6, that would be probably a real finding. But so I wouldn't be surprised if it's improved. But the encouraging thing is the ALT-FOS has come down a lot, which shows it has been a good response.
Yeah, that's fantastic.
Although it's still elevated, it's still not right.
No, but it's come a long way. Celia, you're very welcome. Let me know how you get on. Now, I want to just mention something. One of our doctors, Dr. Trivedi Palak, came on a question time, and at the end we did a little bit about COVID, and he suggested that people should buy, for a small amount of money, an oximeter just in case you caught COVID. Now, I will tell anybody who will listen who wasn't there on the day listening to Palak, and I've sent Palak a message to say that I gave it to that advice to a friend, and it actually saved his life, because this tiny little thing, you stick your finger into, you can buy it on Amazon, and there's very, very good guidelines, very simple to read guidelines on the NHS COVID site. But I would just like, if you could pass on my thanks to Palak, but I would like, James, could you maybe, not everybody that's been in the room today that's with us will know about this. Could you just give us a brief introduction to the oximeter and what it is I'm banging on about?
Yeah, I mean, when the COVID outbreak first started, one of my daughters, who's a consultant emergency physician in Bristol, came and gave us, my wife and I, a pulse oximeter, and we've got it downstairs. It's a little clip that you put on your finger. It records the saturation of oxygen in the blood. It's fairly reliable, and it can be down for many, many reasons. But in monitoring COVID, because one of the main causes why COVID kills you is because of the effect on the lungs. And particularly during the days of the pandemic, when the vaccine wasn't available and people were getting very ill very quickly, the pulse oximeter was a very simple, reliable, and robust way of working out how sick you were, whether you needed to be admitted to hospital, and when you were in a hospital, whether you needed to go to intensive care unit, and in the intensive care unit, when you needed intubation. And when you get to the intubation stage, then that's the time you've got a 50+% mortality. And that's why vaccination is so important, because it can prevent it. There's my plug for vaccination.
Thank you. We need that every week.
That if you're vaccinated, you're not going to infect other people so readily. And a friend of mine died recently. He had pancreatic cancer, and because of people in ITU with COVID, he couldn't get the treatment which potentially could have saved his life. So by not being vaccinated, you put yourself at risk of A, dying yourself, B, getting long COVID, but you're denying other people access to life-saving treatment. So think about it, not just for yourself, but for the wider community and your family and friends. Sermon over, go back to the oximeter. If you have COVID, then it's a very simple thing you can do once a day. You can do it as often as you want, once or twice a day. Plug it on, it takes 10 seconds. You get a number of the saturation, it's a percentage. It'll also give you another thing called the perfusion index, which is not relevant so much, and your pulse, but the saturation. And if it goes below 94%, then certainly you need to seek advice and help quite quickly. So it's a very good way of picking up those people who are likely to get respiratory failure and die, and allow for early intervention.
Yeah.
It's worth having in store, but it is a cost.